Hey guys, today we're gonna discuss exodontia. So, what is exodontia? If we break the term, exo means out and dontia means tooth. Exo means exit or out, and dontia means tooth. So, it's a procedure where we take out the tooth from the alveolar socket. Now comes the definition of exodontia. It's a painless removal of the whole tooth or tooth root with minimal trauma to the investing tissues so that the wound heals uneventfully and no prosthetic problem is created. So it's a procedure where there is painless removal of the whole tooth or tooth root with minimal trauma. This should be kept in mind, with minimal trauma to the surrounding tissue. We don't have to injure the surrounding tissues. There should be minimal trauma to the surrounding tissues. Now comes indications for extraction. So what are the indications of extraction? When are we supposed to do extraction? When there is dental caries, severe caries, and that cannot be restored by restoration or through RCT, then we go for extraction. Or there is pulpal necrosis, or there is severe periodontal disease. As you know, in case of grade 3 mobility, we usually take out the tooth. If the furcation is involved, then we take out the tooth. Then for orthodontic reasons, as in when we have to create space for orthodontic treatment, then we go for extraction. Or in case of Malpose teeth, okay, in case of cracked teeth, when there is fracture that is beyond repair, then also we go for extraction. Also, when there is impacted teeth that is causing pain or infection or swelling to the patient, then we go for extraction. When there is supernumerary teeth, as you know, in some patients we see supernumerary teeth, and those teeth cause problems eventually in the patient, so we better take them out. Then comes teeth associated with pathologic lesions. When there is some apical lesion, when there is some periapical infection that cannot be treated, or there is some cyst that cannot be treated by RCT, then we go for extraction of that associated tooth. Then for aesthetics, we do extraction for aesthetics. Then teeth involved in jaw fractures. Then economics. Discuss it a little bit more. Indications: hopelessly carious teeth, as we already told you, that cannot be restored by RCT, we go for extraction of the teeth. Teeth with non-vital pulp where RCT not indicated. Loss of bony support of tooth, as in case of periodontal diseases, severe periodontal disease. Teeth not treatable by apicectomy. Teeth mechanically interfering with placement of restorative appliances. All right. Then teeth not restorable by operative dentistry. Impacted teeth, as we know, fractured roots. Then root fragments. As you know, we take out the root fragments because eventually it will start causing infection in the patient's mouth. Then comes contraindication. What are systemic contraindications in case of extraction? So if the patient is having end-stage renal disease, if the patient has uncontrolled diabetes and hypertension, see, if the diabetes and hypertension is controlled, then we can definitely perform the extraction taking proper things in mind, like checking the blood pressure. Also, first of all, taking the medical history of the patient is really important. when we should ask for the medical history, drug history of the patient. So if the patient tells you they are diabetic, then you should ask them if it is controlled or if it's uncontrolled, or at least tell them to bring their blood sugar reports with them. Also check their blood pressure before starting the extraction. Then if the patient has end stage renal disease, then it's a systemic contraindication, we cannot do extraction. If the patient has uncontrolled diabetes and hypertension, then also you should refer them to a physician, and if you get a physician clearance, then you can do it. Then if the patient has leukemia, if the patient has uncontrolled cardiac disease, bleeding diathesis, hemophilia, thrombocytopenia, then relative contraindications can be pregnancy, drugs, anticoagulants. If the patient is on anticoagulants, patient is on immunosuppressants or corticosteroids. Then comes local contraindications. Local contraindications as in teeth in tumor or irradiated bone. If there is a tumor in the patient's mouth of the associated teeth, then we should not take it out, as the tumor can spread. So yeah, you should always look into the mouth of the patient for any tumor signs. If you think there is something like that, then just get biopsy done or get the related test done before doing extraction. Then comes relative contraindication. Acute infection, acute gingival infections like fusus pharyngeal or streptococcal infections, acute maxillary sinusitis, extraction of maxillary bicuspids and molars is contraindicated in case of maxillary sinusitis. If the patient is having sinus infection, then don't go for the extraction of maxillary premolars and molars. Then comes clinical assessment. Heavy restoration, grossly decayed, inclined or rotated, firm or mobile. Then you have to see the status of the associated tooth. If there is heavy restoration of that tooth, if the tooth is grossly decayed, if it's inclined or rotated, if it's firm or mobile, if the tooth has supporting structures, maybe diseased or hypertrophied, if there is attrition of the tooth, if there is non-vital teeth, accessibility to the tooth, sound, tooth substance remaining, how much tooth substance is remaining, if it is sound or not. Why is it important? Because we ultimately have to apply forceps or the elevator, so we gotta see first if there is enough structure to grasp it or not. Then comes, that was clinical assessment. Then we have to go for radiographic evaluation. So relationship of associated vital structures, what all you gotta see in the radiograph is configuration of roots, condition of the surrounding bone, periapical pathology. You have to check for any periapical pathology. What's the configuration of roots, if it's curved, if it's straight, right? Condition of the surrounding bone, if there is any bone pathology in the patient, gotta check it. Now comes types of extraction. See, one is surgical and one is simple. So we'll study first simple extraction, then surgical extraction. So what is simple extraction? In simple extraction, usually no incision is needed and no suture is also needed. Whereas in case of surgical extraction, we need to give an incision, then we need to remove the bone. In that case, also we have to give sutures in that cases. Here comes principles of exodontia. Pain and anxiety control. So for pain control, we need to give adequate local anesthesia. We can give PDL injections, we can give palatal injections in case of upper teeth. Then comes anxiety control. We should ask the patient if they have any history of dental anxiety. Then we can reassure the patient, explain the procedure to them. Then only go ahead with the procedure. Sometimes we can go for sedation as well, as the procedure becomes really smooth if the pain and anxiety control is there. Now comes position of the patient and position of the operator. Then comes clear access to and vision of the surgical field. Proper retraction of cheeks, lips and tongue should be there. Good lighting, suction should be there. Then use of control, force, elevators and forceps. The force should be slow, steady and controlled. The path of removal. The tooth should be taken out along the path of least resistance. Then comes position of the patient, chair angulation and chair height. That is very important. So here we have it in detail. Angulation of the patient. Chair is angulated such that operator field is most visible and accessible position. So what is the purpose? The purpose is better vision and better access. Occlusal surface of the mandibular teeth. Now while we are doing the mandibular teeth, the occlusal surface, the occlusal plane should be parallel to the floor or 10 degrees to the floor while the operator is standing in front of the patient. Whereas while treating the mandibular teeth, if the operator stands behind the patient, then the angle of occlusal plane of mandibular teeth is increased until the tooth can be grasped. Now, while working on maxilla, the chair should be angulated so that the occlusal plane of the maxillary teeth is between an angle of 45 to 60 degrees to the floor. So you should keep in mind while operating mandibular teeth, the occlusal plane of the teeth should be parallel to the floor or 10 degrees to the floor. Whereas while working on maxilla, the occlusal plane should be 45 to 60 degrees to the floor. Occlusal plane of the maxillary teeth should be 45 to 60 degrees to the floor. Now comes height of dental chair. So for maxillary teeth extraction, 3 inches below shoulder level of the operator. For mandibular teeth extraction, 6 inches below level of the operator's elbow. Whereas if the operator stands behind the patient, chair should be lowered sufficiently or the operator should use a box. Should use an operating box. As you can see here, we have figures here. We have certain images here like this, like in 4th quadrant you can see. While doing the mandibular teeth, the operator is standing behind and using an operating box. Now role of dentist left hand. During forceps application, during tooth luxation, after tooth extraction. During forceps application, retraction of the lips, cheek, tongue, guiding beaks of forceps onto tooth, stabilizing patient's head during operation on the maxillary and mandibular teeth. In maxilla, index finger and thumb of left hand is used to support the maxilla and rest 3 fingers to stabilize patient's head. Whereas in mandible, index finger and middle finger is used to retract and support intraorally while thumb supports the mandible. If dentist is standing behind the patient, then thumb and index finger is used intraorally and rest 3 fingers support mandible. Now during tooth luxation, supporting buccal and lingual cortices, estimating the amount of pressure applied and amount of alveolar bone dilatation, counteracting the pressure applied, prevention and protection against slipping of forceps and elevators, removal of broken fillings, tooth fragments, or whole tooth before it reaches oropharynx. After tooth extraction, compressing the buccal and lingual cortical plates back into position, examination of the surgical field and detection of sharp, bony edges, bony undercuts, loose fragments. See, here you can see how the grasp should be there using index finger and thumb. Also here in figure E, using middle finger and index finger and thumb. You can take a screenshot of this. Now comes light. Good illumination of the operative field is absolutely essential. There should be good lighting. Now surgeon's preparation. After patient in chair properly adjusted, operator must wear head cap, mask and shatter resistant glasses. Operator must remove rings and watch, should scrub his hands and arms, put sterile gown and gloves. Draping patient. Patient's head, shoulders and chest should be covered with a green drape. Then mechanical principles of extraction. There are three mechanical principles of extraction: expansion of bony socket, use of a lever and fulcrum, and insertion of wedge or wedges. Procedure for closed extraction or simple extraction. Step 1 is loosening of soft tissue attachments from the tooth, luxation of the tooth with a dental elevator, then adaptation of the forceps to the tooth, luxation of the tooth with the forceps, and removal of the tooth from the socket. But first of all, before starting with these steps, you have to sever the soft tissue attachments of the associated tooth to check if there is numbness or not, to confirm the anesthesia, the effect of local anesthesia. You have to sever the soft tissue attachments of the concerned tooth. Then you have to start with all these steps. Use of elevators to reflect mucoperiosteal membrane, to luxate tooth or remove tooth, to luxate and remove tooth which cannot be engaged by beaks or forceps, to remove roots fractured and caries, to loosen teeth prior to the application of forceps, to split teeth which have grooves cut in them, to remove interradicular bone. Now rules of elevators. Never use an adjacent tooth as a fulcrum unless the tooth is also to be extracted. Very, very important. Never use a lingual plate as fulcrum. Always use finger guards to protect patient if elevator slips. Forces applied should be under control. Now here comes an elevator. What are the parts of an elevator? Elevator has a blade, has a shank, and has a handle from where you hold it. Now comes classification of elevators. Elevators are classified according to their use or their form. According to use, we have all these elevators, and according to form, we have straight or wedge type, angular, right and left, crossbar elevator. Here we have types of elevator: Ohm's periosteal elevator, Frey's elevator, Howard's elevator, straight elevator. We have Copeland's elevator, we have Winter's crossbar, we have Warwick James elevator, Cryer's elevator, Beck's elevator. We have mechanical principles involved in extraction. There is some lever principle of first order. Then we have wedge principle. Then we have wheel and axle principle. Then how do we apply elevator?